Dear Mike, after working together on the anesthesia papers of the Society, the clinical one and the pathophysiological one, it was such a great pleasure to be with you together on this conference. But now regarding hemodynamic monitoring, I'd like to ask you to share with us your opinion how to optimize patient hemodynamically during laparoscopic surgery.
Okay, well, optimizing a patient for laparoscopic surgery is very, very different from open surgery. And the reason is the stress on the heart and the cardiopulmonary system are very different. And in my talk today, I stressed how it's very different whether you're head up or head down in position. But the overall physiology is the same. You've got pressure in the abdominal cavity causing an increase in aortic afterload, which increases the work of the heart and decreases oxygen delivery. We see that there's some compensation about 20 to 30 minutes, whether you have a spinal epidural or none of those in place. But it's still very important to optimize patients through the surgery. So I see hemodynamic optimization serves two purposes really. First of all, it is to optimize your heart prior to surgery using fluid, and then secondly, it's to identify whether there are any issues or problems going on during surgery. Now you can use different minimally invasive cardiac output monitors. We've got esophageal Doppler, which looks at descending aortic blood flow. We've got pulse contour wave analysis such as LIGCO or Edwards flow track. I've used all these devices and I think you can get to the same conclusion with them, but you've got to know what you're doing with each of them. But I think the key essentials with laparoscopic surgery is that during the actual laparoscopy, head up, head down, is if you chase the numbers on any of these monitors hard and there's nothing actually going on, you can go very wrong. Okay. So if I could summarize what I do for our patients, is they obviously all are on enhanced recovery programs. They come in, they're not starved, they get oral preload, they don't get bowel prep. So they arrive in the anaesthetic room reasonably hydrated. We then induce anaesthesia. We do, if there's any regional block, we would do that and insert whichever hemodynamic device, either an arterial line or a Doppler, and then take them into theatre. It's at this point we would give fluid up to the point that their stroke volume optimised. Okay. So they're optimised prior to any intervention. And sometimes this be putting the legs up, putting them head down, or pneumoperitoneum. But really all you're doing then is changing the fluid and how it's going around the body. But if you start by having them fluid optimised in the supine position at the start of surgery, I think that puts you in a good position. We then observe what happens during the pneumoperitoneum and early surgery, and you might need another couple of fluid boluses to maintain stroke volume. But then the most important thing, I think, is at the end of any laparoscopic surgery, is to get the legs down, the gas out of the abdomen, and then re-optimise the patient, because then you catch up with any fluid shifts that might have happened during surgery. And then when the patient goes to the PACU or intensive care, we normally would optimise them for a further 4 to 6 hours after laparoscopic surgery, depending what we thought the fluid shifts were, or whether the patient was high risk and had cardiopulmonary problems. And that's effectively it, because most of our patients then, the drip's down and we try and get them feeding very quickly.
Regarding, for example, head-up positioning, do you use vasopressors?
Yes, I think that's a very good point, because by the very definition of going in the head-up position, you're in the hypovolemic model, and you can't maintain blood flow back to the heart unless you do use vasopressors. So what we do, and that's why I think it's important to actually make sure the patient's fluid optimised before you do any of these measures, because then you know you're in the right zone. Whereas if you go straight head up, you really don't know how much it is fluid you need to give or how much vasopressor. So if you fluid optimise the patient and you go head up and the stroke volume drops, you know it's a vasopressor you need to give.
And the rationale is that you separate fluid demands by venous or arterial tone modification by vasopressors.
Yeah, correct. And the big problem we've got at the moment is vasopressors have differential effect on arterial and venous vasomotor tone, and there's patient variability. It varies with age and your inherent arterial compliance. So we haven't got that right yet in anaesthesia.
What kind of vasopressors do you use?
I think in the UK there's basically a choice between phenylephrine infusions, metaraminol, or going to noradrenaline. We'd normally try and use a non-catecholamine, first of all, in our surgery, because we try and reduce the stress response. So we'll try phenylephrine or metaraminol. But if the patient's got a SIRS response post-op, so if they're in oncological surgery, we might well have to use noradrenaline. But obviously, if the patient is an emergency and comes in septic, then noradrenaline is our treatment of choice at that point.
I personally think that norepinephrine is dose dependent. If you have low doses, just to give a tone, it's quite okay, even during surgery, but higher doses are detrimental. That's our opinion in our institution.
Yeah, I think I'd go along with that, but yeah, yes, it's all dose related, and small doses are very effective.
Yeah. And with head down positioning, what is your...
Well, the key thing about the head down position, I think, is the heart failure model. So your heart's pumping uphill against resistance, you're having to have high intrathoracic pressures. So in fact, what you sometimes see is the right ventricle will fail before the left ventricle, because if you've got high mean intrathoracic pressures with a large obese person and a pneumoperitoneum with higher pressures, then you can end up with mean intrathoracic pressures of 25 to 30. So the right heart can really struggle against that. But you often see it actually by the left heart then having problems. And that's why I think monitoring is important, because although you can get it right most of the time by not using these monitors, it just means that you stay on top of things, you catch up on any problems, and also you can maintain the patient in the normovolemic zone right the way through surgery.
My personal opinion is that we can recognize the right heart problem by that the left ventricle turns hypovolemic but not responding to volume. That's a good link. And what kind of PEEP do you use in head down?
We use optimal PEEP. We set the PEEP in order to set the FRC to set the lowest pressure. So I would say probably it's about 4 to 8 depending on the patient. You can use higher PEEPs, but it just depends on the patient and the left ventricular compliance and contractility as to whether they will cope with that.
But you're not worried about PEEP of 12 or something like this, if you think it's necessary?
If you think it's necessary, then to maintain oxygenation. But personally, I find if you can get through that, the perioperative phase, you can always optimise the lungs at the end with higher PEEPs when you've got lost the intra-abdominal pressure and you've not got that two physiological problems going on.
Do you have situations where you start up a discussion with the surgeons that they might change the positioning?
Yes, our surgeons are very aware, both in the head up and head down position, that sometimes patients just don't tolerate laparoscopic surgery very well. And in fact, we have had some instances where we've actually decided to do open surgery because the patient's just not tolerated it, even with a little bit of inotrope. If I am worried about the patient, I would use transthoracic echo as well to try and see what's going on prior to putting the patient on the operating table. But in theatre, it's very hard unless you've got transesophageal echo available.
Yeah, that's a big problem, but at the end, according to my opinion, this is still the gold standard for hemodynamic evaluation in a critical situation, the echo. But the availability and the treatment based on that echo is very difficult. That's my personal experiences with that. So thank you very much. Yeah. It was such a great pleasure to be with you on the conference. And we go on working together.
Yeah, absolutely. Good.
Thank you very much.